like, but have limits.
Yeah, all right, so we are back live, and this is Senate Health and Welfare. We are looking at H72, and getting some testimony from the mayor of Burlington. Welcome.
Thank you.
Hold on a second,
Okay.
Mayor, someone has the sound on? Okay, we're good. So, welcome, Mayor. We can't
Great,
see, we can
I
hear you.
know. This is actually my first week on the job, and I have a new laptop, and I cannot tell you right now why my camera's not on. I'm so sorry, but you can hear me.
We can hear you. You're on Zoom, right? So you
I
can
am
go,
on Zoom. Yep.
is it top of the screen or bottom of the screen?
Well, my camera's on. I bet it's a test
Oh.
the back end of the laptop. So, well, I give short remarks anyway. So how about I just give my short remarks, and we'll pretend I'm on the phone.
Terrific, thank you. And thanks for taking the time to be here. I know that this is a really busy week for you.
It is. Thank you, Senator and Chair Lyons. I really appreciate it. And let me say for the record, I am the new mayor of Burlington, Vermont, Mulvaney Stanek. I'm a former state representative about 10 days ago, serving a portion of Burlington. So I am familiar with how limited time there is. So I also appreciate you seeing me in on this very important bill, H72. I also want to appreciate the full committee for this time, and I'm sorry I couldn't be there in person. I also want to express my appreciation to former Mayor Moreau Weinberger, who testified last week in support of also former legislator. My intention is not to repeat things you've already heard, but to emphasize and underline the importance of H72. I want to be clear on record that as the new mayor of Burlington, I also strongly support H72 and the pathway it provides our city of Burlington pilot an overdose prevention center in our community. OPCs also enjoy broad support of our from our current and new Burlington City Council, who also started about a week ago, and for many Burlingtonians. I spent the last 5 months during campaign talking to folks all across the city, and I was quite impressed with how far people have come with both their understanding of overdose prevention centers and their, frankly, Burlington has really become the epicenter for our state with how many folks are suffering with substance use disorder and the real knowledge within our community that we need to do something different. The status quo is simply not working. We need more tools available to our communities to save lives. And so for folks really understanding that how life-saving, it's not the end-all solution, but overdose prevention centers are really going to provide vital support in communities like mine. We also understand that there is no one solution to the opioid crisis facing our state, but we know what the evidence and data shows, and that is simply that OPCs can save lives. And right now, the need for OPCs is both acute and urgent. If you've been to Burlington, you know how many folks are not only suffering, but suffering publicly within our streets with how acute and difficult the cycle of addiction really is. This is why an OPC pilot project has also had the support of our local Burlington Fire Department, who are emergency responders in our city. They respond to multiple calls a day for the kind of assistance that OPCs can provide. And in the recent months, our rank and file firefighters came up with a pilot program, which has sort of been trying to put Band-Aid on this very critical issue called our Community Response Team, the CRTs. And we're continuing to try to operate that. And even in small ways, we know that has impacted and benefited people who not only to suspected overdoses, providing the wraparound support and care for the additional medical support that folks need who are or either have a combination of living with substance use disorder and are also unhoused or struggling with mental health and also substance use disorder. So it's really quite an acute need in our city. And just last week, which was, I want to emphasize, my first week on the job here. It's been a wild first week with the eclipse and everything else that we've been juggling. I spoke with our fire department about H72, and they reiterated their support for the bill. They also reviewed the bill and had a couple of ways that they thought the language could be strengthened. And I appreciate the committee's openness to modifying language ever so slightly to make sure that we are being clear about the kind of staffing and support and services we need within the OPCs to make them successful. Because I want to emphasize Burlington's ready to put its hand up to be a community support pilot, one of these 2 pilots within the bill. And to do that and be successful means getting the kind of clarity that would help to make these OPCs what they need to be. So those 2 ways that our fire department has asked to modify the bill would be by making sure that the guidelines of the OPCs are a little more specific on the kind of skill set that staff would have within the centers. And they also wanted to expand slightly the scope of one of the data sets to be collected. This is the data around how OPCs impact the number of calls to first responders, not just overdoses, which was in the prior version of your bill, but also for the other related care related to opioid use, such as wound. Now maybe 10 or 12 days ago, when our shelter closed, I had a firsthand experience going in and visiting folks. The amount of wound care and basic medical care that folks do need right now in Burlington is real. And there's a lot of intersection around populations, folks who would also be using an overdose prevention center. So this is really an informed and important piece to consider, just again, tweaking the kind of skill set we need from OPC staff, and then also the kind of data we're collecting from these pilots to make sure that we are aware of the ways to support folks using the OPCs. And finally, our fire department also expressed, and I also clearly agree, that moving forward, we need to ensure that communities who have OPCs receive the necessary funding to support these centers, as well as any additional community supports and services that are part of a whole system of care. And to that end, I would like to ask that we all work together to ensure that clear and consistent funding mechanisms for the opioid settlement funds are timely and sufficient to the communities that are supporting these pilots. And Burlington is ready to put its hand up, and we will be prepared to support any additional services that might be needed to really provide the wraparound support for these OPCs to be successful. And with that, Madam Chair, I believe I reviewed the latest draft that you have. I'm sorry, I don't have the version in front of me, but the latest version posted to your website. And the language that you've added is in line with what our fire department requested. So I very much appreciate that. And with that, in the spirit of being a former legislator, I'm gonna be quiet, see if you have any questions, and just again, appreciate you fitting a few minutes as the new mayor here in Burlington.
Thank you very much for your testimony. And as you know, it would be great if you could send that in to Kiki electronically, so we have a record of that. That would be, yeah, terrific. And your suggestions did make it into the current draft, so we'll, as we go through the draft, our ledge council will be able to point that out to us. Thank you. Questions for the mayor? How does it feel to be mayor?
This is a wild job. I have to say, I have staff, so thank God, instead of being a state legislator. But you know, the eclipse in the first week on the job, that was pretty wild. But Burlington pulled it off. It was a beautiful day, and I hope everyone enjoyed it where they were in the state. And it's a great job so far. So I look forward to partnering with all of you in the legislature on not only this bill, but stuff to come ahead. So thank you.
Well, thank you and good luck. And yeah, you had quite an indoctrination with the eclipse, no question about it.
And the earthquake and all the other wild stuff in this first week on the job.
Everything else going on.
And next time I'll make sure my camera works. Thank you so much. I appreciate it.
Any final questions? Are we good? We're good. So thank you.
Okay.
And now you can get back to the real world.
All right. Thank you all. Take good care.
Take care. Take care.
Thank you.
So let's go through the latest draft with Michelle, and then we will come back to this and do the deeper dive markup, and hopefully we'll be able to vote on it. We may be able to do that as early, probably Friday, Thursday or Friday.
Is Senator Wilson back?
He's testifying.
Good morning.
Good
morning. So we're going to be taking a look at draft 1.2 dated this morning for an amendment to H72. And I did just want to let you know I do have a hard stop. I know you have something else at 11:15, but I do have a hard stop. I have to be in another committee, so I've got 8 minutes to fly through this amendment with you.
That's okay, because we have other things on our agenda,
Sure.
and we can go through it this time, and we can read on our own.
Okay, great. Love that. All right. So starting out, so I did divide the bill because there are two topics here where you're dealing with overdose prevention centers, but you're also dealing with the syringe service programs as well. And so there are kind of reader assist there, and I've divided the sections up so it's reorganized. So in section 1 is where you have the statutory authority for the overdose prevention centers, identifying what an overdose prevention center is, and how they qualify for the immunity protections. So you'll see in section 1, there's a new section 4256. The previous version was in the Good Samaritan law in the chapter 84. And I think I had talked to you about why I thought it should be its own section because it's actually kind of gotten bigger and it's its own thing. So I've created a new section there for overdose prevention center. So subsection A is what an overdose prevention center is. On line 18, you'll see, and you may want to expand that language, but I did add that they also are to provide drug testing services. The chair this morning asked me to add that. I'm just going to kind of go over some of the real differences from what we have talked about before. So subsection B is on the guidelines. So this new proposal would not have entities applying to the Department of Health for authorization to operate the OPC. But the Department of Health would still be developing the guidelines and I put here just as a whole date and just August 15th of 2024, because the way that this version envisions it is that the money would be appropriated and then the city of Burlington would be applying for grants. And so they really can't be developing their grant proposal until there are clear operating guidelines and they can put forth their grant proposal. But that's obviously just a policy decision. So I just put that there as a placeholder for now.
The sooner the better.
You'll see the language there in the sentence starting on line 16 about the operating guidelines. So where you'll see starting on line 18 is that new language that the mayor spoke about that was requested by Burlington Fire Department around requiring OPCs to staff trained professionals during operating hours, who at a minimum can provide basic medical care such as CPR, overdose interventions, first aid, and wound care, as well as ability to perform medical assessments with program participants to determine if there's a need for emergency medical service response. So subsection D, and when we come back to it, I'll spend a little more time with you, but this is the immunity provisions have been restructured based on the testimony recommendation from the Vermont Medical Society when you heard from Jessa a couple weeks ago. And so you'll see that in subdivision D1 are the individuals and entities that would be afforded the protections. Then in subdivision 2 is the list of protections, and it's been expanded beyond just what was in the bill as it came over from the House, which was just providing immunity from criminal prosecution for possession under Chapter 84. And it also now includes, you'll see on subdivision C there on line 7, civil protections and talking about like credentialing or licensing, things like that.
Nice question. Why are the changes in yellow? Normally they are, these are changes to the bill, right? Is that we're going over right now? Just. Okay.
Sometimes, so
Curious.
when we're going from one really close version to another, this is wholly different. This whole bill is very different.
Okay.
There's some pieces that are there, but you have a lot of yellow.
Thank you, yeah. Yeah, restructured.
It's
That's helpful.
restructured,
Okay.
but there's also the money's totally different. There's sections that are gone.
Thank you.
Yeah, but when I do, and each attorney does it differently and committees like it differently, but when I do, and there's like smaller changes, I
Yes.
do the highlight.
That makes total sense. Thank you.
So you still have a reporting requirement for the entity. So section 2, so here's the funding piece. So recall that before the funding was coming through the, I don't remember what Nolan's acronym now.
Evidence-based-
Evidence-based,
Fund.
right. Now, you'll see there's $1.1 million appropriated to the Department of Health from the opioid abatement special fund for the purpose of awarding grants to the city of Burlington for establishing an overdose prevention center. And now I'm thinking about that, was that supposed to, and I wasn't sure if we landed on where the authority or if it should be Secretary of Administration or Secretary of AHS, but you can let me know about that.
Yeah, so who's in charge of that fund? Maybe it is. No,
You would abatement fund? Which-
yes, the distribution of fund, the
It
appropriation.
is,
fund.
I'm
What are
sorry.
you,
I
what
was
are you
talking,
asking about? You're asking about whether it's the Department of Health or whether it's AHS?
well, whether it should be going to the Department of Health
Gotcha.
or the Secretary of AHS or the Secretary of Administration.
Fund.
And I think it should be PH.
Huh?
I think it should go to the health department.
Okay.
But that's a policy choice for you,
Yeah.
but as a placeholder in here, it's VDH.
Okay, well then we'll leave it for now, and then if there's something else for clarity.
And so you might recall that the bill from the House was allowing up to 2 pilot projects. And there wasn't any specific municipality or anyone that it would be designated, people could apply for that. And here it's specifically for awarding grants to the city of Burlington for an OPC. Provided that the grant proposal meets the requirements of the statute in section 1, as well as the guidelines the Department of Health would be developing. And then subsection B would require the Department of Health to report quarterly to the Joint Fiscal Committee, as well as the Joint Health Reform Oversight Committee, just kind of giving you status reports on the update of where things are around the grant proposal being submitted and the funds being distributed to the city.
So the $1.1 million, or the money that's in there, is sufficient to support one pilot program for how many years?
I don't know where the number came from.
Okay, I know.
I think it's the
Mhm.
startup
I'm sharing
for
be there in just a minute.
Okay, so I just want to sort that out because now it's, in a way, we're limiting it to one site
Correct.
in Burlington, and there's nothing in here, I think, going forward, something for us to think about, we don't have to answer it now. But there's nothing in here that allows for expansion should there be funds available, that's all.
So, and I'm really gonna have to go in just a minute.
I know.
Is it okay if I keep?
Yes.
you want me to keep going?
We won't do this to you.
So, the next section, section 3, there's still a study in here, so generally this is the same, but it's just gonna be the study of the one site in Burlington. Generally I just changed the language to clarify that it's this one location. I did add the language in subdivision 6, that was requested by the Burlington Fire Department, where on line 11, they wanted the addition of on reporting on the impact of overdose prevention centers on the number of emergency response calls. They wanted to add the language and other opioid related medical needs. And so that change was made as well. The timeline in terms of the reports is the same, and they're supposed to continue to provide interim reports. The money on page 8 in section 4 is still the $300,000 from the opioid abatement special fund. Then moving on to syringe service programs, you have the technical amendments in sections 5 and 6 that were in the bill as passed by the House. And then in 7, this is language that's contained in the budget for the syringe service programs, the $1.1 million from the opioid settlement fund. And so I've just copied the exact language that's from the budget, but there is additional language. You'll see is that the language in the budget on line 9 says the method by which these prevention funds are distributed shall be determined by mutual agreement from VDH and Vermont AIDS service organizations and other Vermont HIV/AIDS prevention providers. And then the new language that's added is on line 12, with a goal of increasing the number and reach of such programs and availability and efficacy of services throughout Vermont, especially in underserved rural areas.
Good, we need to leave that there.
And then there's just a couple technical amendments I have because of just kind of reorganizing some stuff. And when we come back to it, I can just explain that to you, but it's not substantive. It's just kind of taking some of the other overdose prevention stuff that's gotten through various bills plunked in different
Put things together.
subchapter. And so it all, now that there's starting to be a critical mass of these statutes, I think it makes sense to kind of put them all in one place.
Good. And it gets rid of the yellow. Senator Hardy, go ahead.
The one thing I'm seeing now, Michelle, is we removed the language in section 5 of that the syringe service providers have to be aid service organizations and those things, but then on the money part in section 7, it says just syringe service programs for HIV and harm reduction services, and that there would be a mutual agreement, the Department of Health and Vermont AIDS Service Organizations. So I'm wondering if it should be broader to be syringe service programs, so that it's
Clear.
not.
That's beyond my pay grade in terms of that I don't typically work on that stuff, so I'm happy to do whatever you guys want me to do, and I can check in with Katie or whoever is handling that provision in the budget, if that's Nolan. I don't have any expertise about who
Okay.
does what with regard to those programs, but y'all just tell me what you need and I'm happy to do it.
Okay. Yeah, I just think we wanna make it the broader language.
I agree, yeah,
Appropriations.
so you should do that. I think you should do that.
And I have a suggestion as well.
I'm gonna
Right,
go, but
we'll
I'll
come back,
circle
let's
back.
come back to this, we'll capture you either tomorrow or Friday and
Okay.
try to get, moving on.
All right, just a quick question, did the opioid settlement working group, or I'm not sure your name, the name of that group was, advisors, advisory committee, did they have did they weigh in on where they think the money should flow, or to which organization the money should flow? No?
No, well, there wasn't a recommendation that we have for the 25 budget.
No, they didn't,
24 budget.
we didn't
Yeah,
make a recommendation about where the money should be appropriated, but there was a recommendation that that the settlement fund should be used to fund the overrides. Right, okay.
okay, so, yeah, so let's come back to H72. Please read through the bill, and when we come back, then we'll make discrete suggestions about the wording or improvement. I have one question here. And then try to get to a final draft that we can vote on. That's our goal. And if we can look at the bill this week and then early next week, be able to vote it out. That's the latest we want to vote it out. We might be able to vote it out sooner. We'll see how it goes. Okay, fast track. Nothing's fast again. Okay, thanks for that. And Michelle is no longer here. Nobody is. We'll get to the fiscal note.
On 72. Yeah, whenever you have the bill, I'll do this one.
Yeah, I know, but you're a fact. Yeah.
This is for 233.
Okay, so do we want to go through H 233 with Nolan? Do you want to help us with that a little
Sure,
bit?
I'll be very brief.
Good, okay,
And on 72, I have some thoughts and suggestions to help you think through
thank you.
that money piece we talked about that. So
Okay,
yeah. Again, for the record, when I went to fiscal office, I was very brief on this one. I need sharing capabilities. So this bill, there is appropriation and there's revenue. I'll do briefly. So the section 6 would appropriate $405,000 from the Insurance Regulatory and Supervision Fund, which, by the way, is the fund that funds DFR. and 25 to support these positions. These are positions that DFR has identified they would need to do the work as identified in the bill. There's one exempt enforcement attorney, one classified pharmacy benefit manager investigator, and one classified pharmacy benefit manager licensing. Consumer services investigator. The bill, as recommended by the Ways and Means Commission, should get by the House. The bill would establish fees. The fees they tried to establish were to try to cover the cost of the positions. So there's an application fee of $1,600, there's initial licensing fee of $10,000, and annual license renewal fee of $12,000. That was the jurisdiction of finance committee, but the fees were sort of they're trying to cover the cost of the positions. I think finance will probably weigh in and read on how that.
General question, are the fees, this initial fee, is this based on size of the organization? Is this just, you know,
Right now, I believe it's just generic. I think that they, not to speak for us, but I think they kind of ran out of time to think about that. They were trying to cover the costs.
And again, so fees happen in finance, but it's important to understand that there is funding, possible funding, just as with the other bills we've been looking at.
So anyway, that's all I really have on this.
That's it?
That's it. It's simple. That's the weed
Well, it
bill.
wasn't simple.
Say sure.
Sure.
Thank you.
The fiscal note only covers the positions and the fees.
Okay,
A lot
so
more in the
it's
bill
positions that are needed in order to
to do the bill.
do a bill. Okay,
I'll let the others talk.
all right, thank you. So we have both Sebastian Artwing, we have, is Lauren Bode also going to testify? Pardon me?
I think Theo knows the answer.
Is Lauren Bode?
After, I think she'd like to join virtually, but she has patients, so it depends
Oh,
where that
okay.
patient shows up.
Well, as soon as she links in with Kiki, we'll know, and then we can get her up there.
She did submit written testimony, I believe.
Okay.
She did submit written testimony, I believe.
All right, good. All right, so let's start. Who wants to go first, Jeff? You or Sebastian? Do you?
I'd like to go first.
All right, terrific.
More questions, sure.
Okay.
We have
Board.
the visual.
On board.
Okay. Not the whiteboard.
Good morning, everyone. My name is Sebastian Ortego. I'm appearing for the Department of Financial Regulation. I brought a visual aid that is not a PowerPoint this morning, so I hope you'll bear with me, but as Nolan was alluding to, this is a complicated subject. So what we're going to do in the next 15 minutes is condense down the department's Act 131 report, which is about 60 pages long, into this visual.
So we are so thankful for this.
Very
Great.
Yes, we're going to obscure many levels of detail here to try and get everyone up to a level of understanding where the mechanics of this bill make sense. So like I told House Healthcare, if any of you have ever seen the show The Wire, there's a scene where one of the police officers says that if you follow drugs, you get drug users and drug dealers. And if you start to follow money, you don't know where it's going to take you. And there's a very similar dynamic that plays out in the legitimate drug market. So
I so love that you quoted The Wire. My husband will be so excited.
So starting with the flow of the drugs, drugs start out from FDA licensed manufacturers who sell to wholesalers. And we'll call this price at which the manufacturers sell to the wholesalers the manufacturer list price. So
Take another picture.
there are several categories of wholesalers, but in general, bigger wholesalers sell to bigger pharmacies and to smaller wholesalers, and smaller wholesalers sell to smaller pharmacies. So this group of wholesalers really encompasses a broad array of entities. What's important for this purpose is to know that the price that the pharmacy buys drugs at from wholesalers is generally referred to as wholesale price. Simple enough, right?
Seems simple. That is not though.
No. So, in talking about this bill, you'll hear a couple of other terms for this price. The most important of which is average wholesale price, or AWP.
Yours is better than this one. I can't.
I appreciate that.
Yes.
So what you have to remember with average wholesale price is that this is just what it's at. This is an average of all of the pharmacies around the country buying one particular drug during a particular time period. And it doesn't say anything about what a specific Vermont pharmacy paid for a drug last week. So pharmacies sell drugs to you, the patient. And if you don't have insurance, you will pay whatever price the pharmacist sets for that drug. Usually it includes a little bit of a profit margin for the pharmacist. If you do have insurance, this is where things start to get complicated insofar as following the money. So you have insurance, and your insurance company could negotiate deals with drug manufacturers itself to get all of the different prescription drugs covered, to cover every imaginable condition that you might have. But if you're the kind of insurance company that operates in Vermont, it's very unlikely that, say, Merck or Eli Lilly is going to return your calls. So what you do is you contract with a pharmacy benefit manager to administer your pharmacy benefit. So pharmacy benefit managers do a few different things, and we'll list them from most important to least important. So most importantly, pharmacy benefit managers pay claims. Meaning that for insured patients, it is the pharmacy benefit manager generally that reimburses the pharmacy. The other thing that pharmacy benefit managers do is claims processing. So they're the ones that check your prescription drug benefit and run it through the system. That way, at the other end on the pharmacy, you just pay whatever your copay is. So processing.
A question here.
Yes,
So the patient information is available to the PBM.
yes,
And so it's also available, it's available to the insurance company, obviously.
yes,
But now it's gone out beyond the insurance company, the provider, and the
Yes.
pharmacist, it's out in the PBM.
yes.
Mhm.
So the last thing that PBMs do, and again, this is a simplification, and we're leaving out a few things for the sake of time and simplicity, is setting the formulary. So what is the formulary? The formulary is the list of drugs that is covered by your prescription drug plan. Usually formularies are in tiers. So what will happen is that drugs A, B, C might be on tier 1, drugs D, E, F will be on tier 2, and drugs X, Y, Z will be on tier 3. And tier 1 will have a $10 copay, tier 2 will have a $20 copay, and tier 3 might have a $100 copay because those drugs on tier 3 are super expensive. It is the PBM that helps to establish that on behalf of the health insurer. The really important thing to know for this purpose about the formulary is that it's usually divided by how much the patient will have to pay out of pocket at the pharmacy. So that brings us to the relationship between the PBMs and the manufacturers. So in this model, which does not show the vertical integration, the PBM does not buy drugs directly from the manufacturer. They're on the money track, not on the supply track. So why do PBMs have relationships with the manufacturers? Manufacturers give PBMs rebates for favorable formulary placement. So what Merck will say to Express Scripts is that, hey, we've got this drug and we'd really like it to be covered on tier 2 of your formulary instead of tier 3. So we will give you a $50 rebate per script to bump it up to the next tier of the formulary. And the pharmacy benefit manager will happily accept that deal. Yeah.
That $50 rebate, is that, does the pharmacy, do the PBMs keep that money, or is it?
We're gonna get there.
Okay.
So the relationship right here is for rebates. Okay, and does the PBM keep that money? That's a good question. It depends on the contracts the PBM has with its insurer or health plan clients. Some contracts and some state laws require either full or partial rebate pass-through, where the PBM will essentially pass all rebates down to the plan, which will then use it to lower everybody's healthcare costs. For instance, like premiums will be $50 lower than they would have been. Or sometimes PBMs will keep these rebates and it goes to their profit. It all depends on the contract between the PBM and the insurer and the applicable state law. So the next part of this is the relationship between the PBM and the pharmacy. So just like insurers have in-network providers, PBMs have in-network pharmacies. And the PBM will reimburse pharmacies that are in network for drugs they dispense to insured patients. So the term that will most often come up here is the maximum allowable cost, or MAC. This term only applies to generic drugs. But for all drugs, it is the PBM that reimburses the pharmacy. One thing that you might notice is that the MAC price is over here. The price PBM reimburses the pharmacy. The price that the pharmacy pays for its product is over here. And what I really want to illustrate to you is that the price that the pharmacy pays will have nothing to do with the price that it gets reimbursed. And this leads to situations where the pharmacy will be reimbursed less by the PBM than the amount it paid for the product. Any questions so far?
No, yeah, why did that all happen? How does that all happen? Where is the regulator? I mean, yeah, there's a huge question there.
It can be more, and this is a point where if you were to ask PBMs, which I recommend that you do, they will say that especially for generic drugs, which have a lot of price volatility because the cost of ingredients can go up and down. What this system allows is that when the MAC is less than what the ingredients cost, then the health plans are protected from that price volatility. And when it's more, the pharmacies get a little bit of extra money. So if you want more information about that dynamic, I would recommend that you speak to the PBMs for more detail on how these contracts work. For right now, we're just trying to keep it simple. Okay, so now the last part of this overview that I wanted to share is about vertical consolidation and how that impacts small pharmacies. So this has been a relatively simplistic model so far, where every entity in the chain is separate. But increasingly where the industry has gone to is consolidation. So insurers will own PBMs, which will in turn own pharmacies. And we have
Aetna's an example.
yes. They're not the example that I'm going to use right now because CVS is.
CVS is the other.
Yes, Aetna is CVS, but it's a lot easier to say CVS. So your insurer will be, say, Aetna. Aetna owns CVS Caremark, which is the PBM. And then they also own CVS Pharmacy. So where we end up is that independent pharmacies basically have to compete against these vertically integrated behemoths that own everything on the value chain. And in some cases, they have relationships with wholesalers too, meaning that independent pharmacies essentially have to buy products from their competitors and be reimbursed again from their competitors. And it's this dynamic that puts a lot of pressure on our independent pharmacies. Okay.
So can Senator Hardy take a picture of that?
Yeah, is it, are you
finished making
Yes.
changes?
okay.
That would be good. We need this on our webpage. This is awesome.
Wait, there's a, yeah, there's an article here. There, you gotta look up. You're part of the picture.
Oh, we got two pictures.
Very good
Yeah.
picture.
And zoom in.
Okay.
Now. All right, I'll send it to you, Kiki, so you can post it.
Right. So again, remember, this is very simplistic and just for
We got it.
understanding. Now, I'll move to the bill and note that as we said in our Act 131 report, the department is in support of licensure of pharmacy benefit managers. And the reason that we are is because when we have the authority to take away an entity's license to operate in the state, we find that it gives our enforcement more teeth. We are neutral on other parts of the bill, except for one that I wanted to raise with the committee, and that's in subsection 3613, which I believe is in, let me look at the text. I believe it's in section 2 of the bill as passed by the House, but in any event, this language is, it begins on page 12. And the part of this that the department objects to begins on line 13, where the Office of the Healthcare Advocate would have the right to review copies of all materials provided to the department by way of enforcement actions. And we believe that the healthcare advocates right to review such material would impair the department's ability to conduct investigations, because one of the bedrock principles of the department's in general market conduct authority is that anything that we collect in the course of a market conduct investigation is confidential until such time as a stipulation and consent order is signed, or there is litigation about the subject of that enforcement action.
So thank you for that. That helps us with looking at the bill, and we do need to hear from a PBM, of course. Good questions for Samantha. Do you have anything else? to
Nope.
add?
That is it.
And do we have your comments on the bill, just as short comments? I don't see it on our webpage, but
I'll submit something in writing to Kiki.
that would be helpful.
Right, thank you.
Thank you very much.
Wait,
Thank
you
you.
can leave the whiteboard.
Yes, I'll, any other witnesses want to use it,
Yeah,
I'll leave it right
Temporarily.
there.
Yeah, it's great.
Really good. Thank
You don't
Good.
wanna give me
All
that.
right. Jeff doesn't need the whiteboard.
No, you don't want me to have that.
No. It would get a little much more complicated, I know that.
Very,
Very quickly.
thank you for the record, Jeff Hodler, Director of Market Pharmacy Group. I first certainly support the bill H233. This is a necessary step. Vermont has been at the foreground in terms of having statutes on the book to protect pharmacies, to expose any bad practices. They just don't have enforcement behind them. So thankfully, the Department of Financial Regulation has really recognized all that, and kudos to Sebastian, who in my 10 years coming up here and hearing one-on-one speeches about how pharmacy works, mostly Butcher, I think he did a fantastic job.
We should all repeat that.
Mhm.
Thank you. Excellent
Thank
job.
you.
I will say, you should add a budget line in there for
Yes.
skateboard and or dry racing partners.
So I'm in my graduate office where I got all the metabolic pathways.
One point I do want to clarify about the wholesalers. There are 3 big wholesalers, 4 really, I think of the 4 dominant wholesalers in the industry. Doesn't matter what size pharmacy you are, you buy from them. Okay, so it's not a limitation as to what we can buy, or from who we can buy. It's, they're all there, they're all available for you. Pharmacy contracts with wholesalers are something of concern that I think the department is going to be diving into as they uncover this stuff. There's a lot of requirements about purchasing minimums, the interplay between the wholesaler's other affiliations, i.e. does the wholesaler participate in a group purchasing organization that's owned by the PBM? That happens. The impact about the formulary fees, I don't like to call the fee that Sebastian said where the manufacturer pays the PBM to put the drug on the formulary. I refrain from using the word rebates on that because it is specifically called something different to avoid contract violations. A formulary fee. So everything is in the words. It's very, very, very crucial that somebody's paying attention to it, and no better people than the Department of Financial Regulation. They know what's going on. They have a great idea. They certainly have the legal expertise to dive into this stuff and figure it out. It is there, and I'm confident that our Department of Financial Regulation will do a great job, provided they have the resources. The other point I wanted to make, which I think maybe there's something in H233, which, you know, in a really high level, you know, this is a bill giving resources to the department to properly regulate and administer the rules of the state to the three entities that dominate the pharmaceutical market. And one of them about the MAC pricing. You know, we talked about, you know, MACs do typically apply to just generics, but the way we structured the law in the definition of maximum allowable cost, which is, I think, moved in H233 as one of those pieces that is law but moves. There's a question, we designed it so that it applies to all the different anagrams that may come up. AWP, WAC, AMP is another one, NADAC, acquisition cost, whatever you want to call it, it's supposed to be encompassed by that, which by rights we might want to consider, does that apply to brand name drugs and biosimilar drugs? What we're seeing in the industry today is a lot of brand preferred over the generic drug or over the biosimilar. The drug Humira, which is one of the blockbuster drugs for the last 20 years, goes at a rate of $6,000 a box. Has biosimilars.
Increased 50% over a 5-year period
Yet the biosimilars are not covered
in that biosimilar.
by any of the plants in operating group. So there's a question, why? What's the real cost? Where do those biosimilars stack up? And they might be correct in doing so because of the back end rebate structure, but we ought to know as consumers, and certainly from a regulatory purview, they need to, that we're doing a good job. Otherwise, we're basically contradicting our generic substitution policy, the biosimilar policy that even the insurance plans fought for to get on the books when the FDA was considering the public health benefits. So there's a lot happening. I really want to kind of focus on answering questions and help steer you guys into understanding why this is such a necessary step. In conjunction with what you thankfully did pass the S98 language about the Green Mountain Care Board expanding its role into understanding accessibility and sustainability. Because you will have an access to pharmaceutical care issue this summer. Cannot wait any longer. There are 16 operating independent pharmacies left in this state. They are all dying on the vine. I submitted a survey that was done by the National Community Pharmacy Association just this February, and talking about 30% closure rates across the country. We can expect something higher like that. It's for real. The plans for 2025, the solicitations, I'm a member of what's called a Pharmacy Service Agreement Organization Board, which is a board run by the wholesalers to negotiate your reimbursement. So the wholesalers, not only do they affect your cost of goods, they do also play a part in your reimbursement strategies. Not to mention the fact that that might be a conflict of interest if they are in a GPO and it's at PBM. It's said, it happens. There's a lot that's happening. But The plans for 2025 are already being solicited. We're seeing a lot of plans that are a decrease of 2 to 3% from the current rate, which is a decrease of 2 to 3% from the previous rate, which is increasingly below the NADAC price. So that pharmacies are continually being reimbursed below the acquisition cost of the drug. This Sunday, I just had a company-wide meeting with my senior team, so all of my pharmacists and all of the managers and leaders. We made a group policy as to how are we going to tackle the continual underpayments for medications, because they are hurt. They are not getting answers when we appeal the price of the drug. We are not getting necessarily prior authorizations to substitute for a more affordable drug for not only the patient, but also for us. So what do? Do we turn that business away? Are we allowed to, actually, I even posed the question, I believe, to Sebastian and many other people, am I allowed to balance bill like every other provider sends me a bill when the insurance company doesn't pay them their rate on commercial? I've always thought that was prohibited and I never participated in that. So why all these things happen and why pharmacy is dying and why we have an access problem and it's going to get worse needs to be addressed. There really is no question about it. It is the smartest investment the state will ever make to start uncovering what goes on in prescription drug law so that you can see how it relates to every business operating in the state. You know, how can we improve upon it? How can we improve upon the healthcare of Vermonters? And most importantly, you know, what lessons can we learn and how do we move forward knowing what we are going to do?
So, yeah, good.
Very
So
important.
we have some of your comments. Helpful. And if we don't, we should get them. I know we have some previously, but the horizontal vertical integration thing that's going on, it's just like, it's going to destroy access.
Yes.
I want to give, Lauren Bode an opportunity to testify. I think she's on this, she on Zoom.
It's not.
She's not, okay, I almost hold that thought, so I didn't move her up the flow, but if she was there, we want to make sure she had an opportunity, so we'll just continue with questions now.
Yeah, good testimony. Just curious, anybody in the industry has gone out to produce a return on investment analysis of any type, just to kind of frame what this might, how this might help the state or Medicaid, Medicare, initially, so.
I have, yes, there are studies out there. Actually, the state of Kentucky just yesterday just passed language for a new model. You're increasingly seeing this model being proposed out there in the industry. Actually, I would venture that a lot of the commercial solicitations for 2025 are going to include maybe something along these lines of some kind of comparison to the NADAC price. So the NADAC price file is the national average drug acquisition cost, reported by an accounting firm in Virginia at the behest of CMS. It's updated regularly. It is the basis for Vermont Medicaid's reimbursement strategies. It's a NADAC plus an appropriate dispensing fee, which we strongly support. Cuban drug cost drugs essentially did the same thing. Amazon, Berkshire Hathaway, when they were writing their commercial book for their employees, they did the same thing. Understanding what the real acquisition cost of the drug is, how much of it the formulary fee, is that really adding to that? The Janssen Transparency Report, which is published every year, highlights the number about 51 to 52% of the list price from the manufacturer to the wholesaler is the formulary fee paid to the PBM. So is there a better model? It definitely worked differently in the 80s when I was first introduced to the pharmaceutical world. And it has gone up since. So it's time to really evaluate where are we at, make a comparison of apples to apples, and see where the savings are. I can tell you that in my company, I moved away from the exchange products because one, I'm a pharmacy. I have access to these medications at my cost. I can do a better job managing my employee benefit package. And guess what? I saved 6% last year, and I had 0% increase this year. there is money to be saved. You just need to understand how it's all connected to each other, how you can properly insert without overstepping and creating future ripple effect problems. And that's why it's important for the department to have their resources along with agreement with care board and their resources. Combined, it is the perfect first step for Vermont to get on balance and then start doing some real comparative and analytical work. And I think we should start with the NADAC price file because it's publicly available. Honestly, I see no reason why in 2025, the insurers can't say our plan has a NADAC comparison to this.
Thank you. It's been a great day.
Yeah.
Yeah, very good. Sebastian, thank you. I'm just looking around the room, we actually have 0 time. But if there are any comments that you'd like to make, let us know and we'll try to accommodate that. And I know others on the committee may want to hear from folks, so let me know who might be important. We don't do it right now, but just email us.
Did we walk through this bill? Was I at time, just it?
Yeah, we did.
We did.
had
Okay, I must have missed it.
the reporter is right behind.
No, I mean, with the attorney.
With the attorney.
To Jen, it's
Yeah.
Jen's bill, I'm assuming.
Yeah,
Okay,
we
I
did.
must have missed, that was the morning you weren't here.
One last comment, go ahead.
I would love to chat, Representative Mari Cordy, sponsor of the bill, H 233. I would love to chat a little bit more about a couple of things I didn't mention, which Jeff did, the dispensing fee
Yeah.
bill in Kentucky, and the rebate pass-through.
Yeah.
Another time.
We'll get to that, we'll do that. Thank you. We've got a lot, there's a lot embedded in the bill, not the least of which is this very clear explanation of drug pricing, which I love.
Really, it's.
I actually
Don't
used,
draw on it.
I actually, wait, I
need
used
another picture.
I actually used this at a.
We need
at a
to
talk
spray
with
it with
Ashley,
that.
and everybody is going, oh no. So we're gonna follow draft, we're gonna go off live and we will come back to this. This is a real priority, I think, for all of us.